Next, David Holmes and Dr. William Abraham, Professor of Internal Medicine, Physiology, and Cell Biology, and Director of the Division of Cardiovascular Medicine at The Ohio State University in Columbus, Ohio, discuss monitoring heart failure to improve patient outcomes.
So let's talk about then the goal. What are the issues as we think about improving strategies of care?
Heart failure is a major and growing public health concern associated with more than 1 million hospitalizations per year in the United States and the highest 30-day readmission rate for any medical or surgical cause of hospitalization. The goal here is clearly to improve upon those statistics, to reduce the total number of hospitalizations, and to reduce that staggering readmission rate.
In addition to that, this is going to be one of the metrics of quality of care. So society is going to look at hospitals and say, how are you doing? Because that will tell us whether you're a good hospital or not.
Absolutely. So the implications are not only for our patients to help keep them better and keep them out of the hospital, but for the healthcare economy as well.
So as we think about then the issue, how might we improve strategies of care? Lots of different ways. Talk a little bit about that.
Yeah, so we have established drug and device therapies that have had a significant and favorable impact on heart failure, but despite those therapies, hospitalization rates remain high, and our focus has really turned to telemonitoring and telemanagement of heart failure. Can we use physiological data obtained remotely to better improve the treatment of the heart failure patient and reduce the likelihood of them becoming decompensated and admitted to the hospital?
So what things would you measure?
Well, of course, the simplest things, and those things which we've measured for some years now, include patient signs, symptoms, and daily weight changes. But we've learned over recent years that the sensitivity of those parameters is not very high in predicting a heart failure hospitalization. So we're now turning to more physiological parameters such as intrathoracic impedance monitor, daily activity monitoring, monitoring of autonomic function or biomarkers, and perhaps most exciting and recently under investigation are implantable hemodynamic monitors which directly measure intracardiac and pulmonary artery pressures.
And is that the sort of focus of your investigations currently?
It is, and it's predicated upon the following. One, the earliest changes leading to decompensation of heart failure are pressure changes. They precede changes in biomarkers, impedance, and the onset of worsening signs, symptoms, and weight changes. Secondly, those other parameters are really crude measures of changes in pressure. So we use signs, symptoms, weight changes as crude measures of changes in pressure. With these new enabling technologies, we can measure the pressure directly, and with all of that, get a more precise estimate of how the patient's doing. And really the goal here is not to react to changes in pressure, but it's to lower the pressures into a normal range and keep them there, really a more proactive or preventive approach to heart failure hospitalization rather than a reactive one.
So what specific pressures do you measure?
There are a number of devices under investigation, including pulmonary artery pressure monitoring systems and left atrial pressure monitoring systems. And in addition to the diagnostic aspect of these systems, the method of use is also important. And perhaps most importantly, we're moving in heart failure to a physician-directed patient self-management approach. Much as we use in the management of diabetes, we can now use these pressure monitoring systems to provide feedback directly to patients and allow them to self-manage their pressures within physician-prescribed guidelines.
Now, you mentioned physician-directed. Is this healthcare team-directed? Does it have to be a physician, or could it be a nurse practitioner, or should it be a nurse practitioner?
And in fact, the reality is that in our clinic and in the studies that we've done to date, the majority of the follow-up of these devices is really in the hands of the nurse or nurse practitioner. So it is a clinician-guided, and it really involves a multidisciplinary team approach.
So tell us then about the results of your study.
I think the two most relevant studies are the Champion trial, which was a 550 patient randomized controlled trial of the pulmonary artery pressure monitoring system, and it demonstrated a 37% reduction in heart failure hospitalizations over an average follow-up period of 15 months. And the second trial, which I'll mention, is called the homeostasis trial. This was a smaller study, a 40-patient observational trial, really a proof of concept study that introduced this concept of clinician-directed patient self-management, where we put knowledge of left atrial pressure directly into the hands of our patients, and they would take a little bit more diuretic each day or a little bit less depending on their prescription, their clinician prescription, and the results of their daily left atrial pressure monitoring. In that study, there was demonstrated also a highly significant reduction in heart failure hospitalizations, and that trial has served as the basis for a now ongoing study in more than 700 patients called the Laptop HF trial, which is attempting to confirm the utility of this approach to heart failure management.
So what sort of patients are you enrolling in this? What sort of patients would be good for the device as we think about the future of this?
Yeah, we're starting with patients who have more severe heart failure, who are at the highest risk for hospitalization or for hospital readmission. So in general, patients who have been hospitalized within the past 6 months or a year, patients who continue to be in New York Heart Association Class 3 or perhaps ambulatory Class 4 despite therapies and are at the highest risk. That being said, patients with milder symptomatic heart failure are also at risk for hospitalization, and we're working to devise better ways to monitor those patients as well. I'll mention one emerging technology that uses radio frequency, essentially a radar technology, to precisely measure the density of water in the lung non-invasively with a wearable patch. That might be a good alternative for the Class 1 or Class 2 patient, and perhaps in the Class 3 or Class 4 patient, the risk-benefit would favor implantation of one of these hemodynamic monitors.
One of the things to consider is the fact that when we gave patients the ambulatory blood pressure machines, sometimes they would come into the office and they would have recorded their blood pressure 30 times in the day and then pointed to you, the physician, and said, gee, at 11 o'clock it was really high. What do you want me to do about that? Do we face overwhelming the patient with data that they are then expected to manage? For example, if their left atrial pressure rises by 2, is this an emergency thing? Is it something that's going to really upset the apple cart? Can you talk a little bit about the effect on patient sort of quality of life, satisfaction, and the ability to make these changes without dramatically changing their lifestyle?
With technology, there is a risk of too much information, and we've tried to simplify that in developing more of a green light, yellow light, red light approach to patient management, or an optimal high-low approach. So we try to keep it very simple for the patient. It's not the specific number that is as important as the range. If the patient falls in a high range, they're instructed to take a little extra diuretic. If they fall in the low range, they're instructed to take a little bit less diuretic. And then, of course, if they fall in the optimal or normal range, they take their normal or prescribed diuretic dose. We also have learned that earlier generation devices measured the information continuously, probably too much information. So now we just take a measurement once a day to try to keep this simple as well for the patient and to avoid this information overload. And our experience has told us that patients become engaged. They get a sense of having greater control over their own illness. And we have seen patients enrolled in these trials with as little as 8th grade educations, elderly folks as old as 90 years old, be able to manage these systems very well. So I think it's a positive, which perhaps was put best by one of our patients who said, you know, I used to think that I only got to see you once every 3 or 4 months, and now I feel like I'm connected to you every day. And that gave the patient a great sense of reassurance that we were watching them all the time.
And maybe that's a great way to wrap it up, to say, I'm connected with you. I'm a patient. I'm connected with you every day. And I am then able to make decisions after having been connected with you every day to improve my outcome. Bill, it's been great visiting. Congratulations on your work. We look forward to hearing about it in the future.
Thank you very much.